Today, we're going to discuss a new clinical practice guideline from the Alzheimer's Association on the evaluation and testing for Alzheimer's and related dementias. This is an important area for us in primary care because we are usually the first clinicians that patients go to when they're concerned about possibly having memory problems or dementia. And it's a challenging area. This is much needed guidance. The Alzheimer's Practice Guideline recommends essentially a three-step approach to diagnosis. The first step is to assess whether there's a cognitive deficit. If there is a cognitive deficit, then assess whether that deficit fits mild cognitive impairment or whether it fits mild, moderate, or severe dementia. Remember, the main difference between MCI, mild cognitive impairment, and dementia is that dementia, by definition, interferes with the capacity for independent, everyday activities. It's important to get a history from both the patient, but also a significant other with attention to activities of daily living, time course of the cognitive decline, and any potential precipitating factors. For a variety of reasons that range from impairment of memory to embarrassment to a lack of self-awareness, patients themselves might not always give the best history to provide a complete picture of what's going on. In addition, the guidelines recommend performing a mental status exam using a validated instrument like the MoCA or the Mini Mental Status Exam. If that evaluation shows that the patient is cognitively unimpaired, then no further evaluation needs to be done, and we can educate them about brain-healthy behaviors and, of course, plan for follow-up assessment. If the patient does show evidence of cognitive impairment, then it's important to define the effect of that impairment on their function. The second step in the evaluation is to characterize the clinical profile of a patient's cognitive behavioral syndrome. What this means is that we want to the degree that is reasonable, delineate the domains of impairment, which might include memory, executive function, attention, language, and emotional and social functioning. Here's where neuropsych testing can be helpful if it's available. These first two steps allow us to develop a plan for personalized care and support. The third step, then, is testing to help figure out the cause of the patient's symptoms. It's important to differentiate Alzheimer's disease from Alzheimer's disease-related dementias such as frontotemporal dementia, Lewy body dementia, multi-infarct or vascular dementia, or mixed vascular and Alzheimer's dementia. It's also important to determine if the cognitive decline is caused by or, and this is important, or being made worse by other diseases like depression, sleep apnea, B12 deficiency, or others, or if factors like the effect of medications, two examples, anticholinergics, alcohol, are contributing to the cognitive or behavioral symptoms. Step 3 of the evaluation includes ordering what the guidelines refer to as Tier 1 studies. And they say this because these are studies that are considered routine and should be done for all patients in the evaluation of MCI or dementia. The recommended tests include a CBC with diff, complete metabolic panel, TSH, vitamin B12 level, homocysteine level, a C-reactive protein, and a SED rate. In addition, it's recommended to order imaging, preferably a brain MRI without gadolinium, or if an MRI is contraindicated, then a non-contrast CT scan. The MRI is important because it can rule out tumor, it can show multiple infarcts, or it can show regional atrophy patterns that may suggest specific neurodegenerative pathologic changes, but it's important to recognize that the MRI is not in any way diagnostic. The guidelines recommend against using the term labs for reversible causes of dementia because the labs only rarely uncover a cause for dementia that is reversible. They cite a meta-analysis from a number of years ago that showed less than 1% of dementia syndromes were found to be reversible, although 10% of people with dementia have a common comorbid condition that might be contributing to their degree of cognitive decrement. This certainly fits my experience. The preferred terms for Tier 1 testing, then, is a cognitive lab panel. Additional testing, termed Tier 3 and Tier 4, are only recommended when necessary based on individual assessment. These tests can include an ANA, folate, ammonia level, lead, Lyme antibody, RPR, HIV, and sleep studies. Of course, there are plenty more tests that are on the map that can be done in specific circumstances. So if you think about it, what haven't we talked about? Well, how about blood biomarkers for Alzheimer's disease? I recently reviewed the Alzheimer's Association's work group recommendations on revised criteria for the diagnosis and staging of Alzheimer's disease. And the key principles which that guideline laid out was that Alzheimer's disease is defined by its biology, neuropathologic changes in the brain, like deposition of amyloid and tau protein. We are now on the cusp of having blood-based biomarkers, amyloid beta and p-tau are the most commonly cited ones, that will enable us to either rule in or rule out Alzheimer's disease with a high degree of accuracy. It's important to recognize that while the biomarkers are promising and will be incredibly useful, they still need to be further validated in large populations. And while the blood biomarkers can now be ordered through many lab tests, there is not yet a fully FDA-approved biomarker. In my opinion, start to understand the place of blood biomarkers now, because once these blood biomarkers are regulatory approved, they will become a routine addition to the initial panel of laboratory tests that we typically order when working up patients for dementia. Finally, I was thrilled to see that the guidelines specifically acknowledge that in the primary care setting, 2 or more problem-focused visits would usually be required for the assessment of dementia. I certainly find that to be the case. When there's uncertainty with regard to diagnosis, early age of onset, rapid progression, and/or the consideration of biologic therapy, then referral to a dementia specialist makes sense. This is an important update, and it provides a clear, straightforward approach which allows us to evaluate patients for dementia with confidence. I'm interested in your thoughts. Please leave them in the comments section below. For Medscape, I'm Dr. Neil Skolnick.